Thanks, Chad. That was a fantastic presentation. All of us face these very complicated anatomies on a routine basis. Just a quick question from my side, which is, even in the most challenging anatomies, the kind of the impact of a clip on a patient is very minimal. Even an attempted clip case, the safety profile of the device or a clasp, whatever kind of edge-to-edge repair technique you use, is very low. And even if it's an unsuccessful procedure, still the clinical impact on the patient is relatively low versus a lot of these newer technologies that are coming in. Their safety profile is certainly a little bit something to be worried about. Is that going to be a big thing moving forward as we start taking on these complicated, repair anatomies? And are we going to, kind of consider that more often?
Yeah, I think that's a good point. I do think the anatomic considerations for technology can and clearly have an impact as the safety profile. We have become more aggressive with on-label technologies, as you said, with leaflet plication. Should we be doing a cleft posterior leaflet and using convergent clips, or should we be going towards placing a Tendyne or other TMVR device? So I think it's going to be multidisciplinary team involvement. The trials are going to be really additive to tell us how these other technologies will apply. And maybe it's addition of multiple technologies. So I think, the team approach really holds true in this scenario, not just with the interventionalists, but also surgeons and imagers. Imagers really help guide us in this space.
Chad, can I ask a question?
Sure.
Great talk, by the way, and you showed some really nice images with fusion imaging. I was quite excited with the technology a few years ago, but it's sort of, to me, fallen to the wayside for LA closure. What do you think? Is there much added value for mitral interventions, especially when you sort of go into the TMVR world? How much added value is there with these fusion imaging technology? Obviously, there's a lot of costs associated with that.
So it's a great point, and I've been excited about this space for 10 years now. And the evolution of this technology is not really is not evolved, and it's kind of a shame, because I think part of it's embracing the technology as physicians or as teams within the room, and then utilizing it in conjunction with device technologies. So part of the failure is us as physicians working with industry to advance the technology. And then part two would be our failure to push industry with device technologies to really hone in as to how these technologies can best be utilized. Just like any device technology, as we do a trial, we really, fine tune our techniques for using the device. The same needs to happen with the imaging technology. So, for example, right now with TMVR, we should be really, as a team, as a physician community, really be honing in as to what are some of these fusion technologies and how can we advance them. So, I absolutely agree. It's, for me, I use the technologies on all my cases. But if we shut it off on certain cases, the cases still go on. So I think at a point where, we need to progress in this space, and we just haven't gotten there yet.
Well, Chad, great talk. Quick question, though. If you had your crystal ball in front of you, what do you think? 5 years from now, annuloplasty percutaneous with MitraClip or TMVR lampoon? Do you think the skill sets for both, which one do you think is going to be more ready for prime time?
Great question. It's how these technologies evolve. I mean, we're in the TMVR space, and it's really remarkable to do. You're looking at an open case now with transapical access, but within 10 minutes of implanting a device, from apical entry to deploying a device, you see no regurgitation. And the thinking and adaptation by a physician, versus a MitraClip in a complicated flail gap MitraClip case where you need multiple clips. It's quite remarkable, TMVR technology versus TMVR repair technology. So, I think these technologies have to evolve. And like anything, technologies evolve, like in TAVR, that become less dependent upon the operator. So we evolve to a point where the technologies iron themselves out, that becomes easier for the physician and safer for the patient. So, the hope is that that's true, and like it was in the TAVR space, this will be true in the mitral space.
Chad,
Well,
quick
I
question.
think
This is wonderful. Regarding device selection, so you had mentioned in a case where there was a cleft, for example, where you might use a couple clips and be creative in your deployment. That may be something that you would consider for somebody who's very elderly and really has no other options. But for somebody who might be a little bit younger, although maybe still not a great surgical candidate, where you have to worry about sort of the long-term lifetime management, how do you allow device selection to enter into those decisions?
Yeah, I think it has to be, you have to understand who the patient is, and definitely a team approach. I mean, you can do, any interventionist can do aggressive techniques and convergent clips. You have to be able to be smart about it. There's patients that are candidates for open surgery and repair, patients who are not candidates for trial. Maybe this would be a better trial candidate for TMVR device. But if you can't fit them into a TMVR device trial and they're not surgical candidates, then I think, an option for convergent clips is the best team approach for that patient. So I think you really have to take all those things into consideration.
Fantastic. Well, that was great. And I think that discussion illustrates that you can't treat what you can't see. And we still have a lot of work to do there.